another story, something to get off my chest.
Hello and welcome to another Piper Pod. Today we're going to continue with the pharmacology theme and we're going to have a look at something a little bit different to the usual side of the house, and we're going to look at the legal and ethical considerations associated with medication. Now this is designed obviously to illustrate the legal requirements and ethical considerations, but whilst going through it, just have a think about your practice, especially your practice in the military, and think about ways in which we can handle medication just a little bit better. So starting off, looking at the overall control of drugs in Australia. Now there's a lot of acts, regulations, legislation that you'll find throughout Australia. Now the way Australia works is we have Commonwealth legislation and then state and territory acts that control all aspects of medication, from what medications we can use, how they're sourced, imported, exported, stored, prescribed, dispensed and administered. It goes right through. Now the main Commonwealth acts is the Therapeutic Good Act. Now that essentially is governed by the Therapeutic Good administrations, and what they do is they decide what drugs can actually be used within Australia. That's one of the things that they do, is decide which drugs meet the requirements and the safety aspects and the scientific proof of Australia to be used here in Australia. The poison standards is where we get a lot of our schedules for medication. So it obviously illustrates everything to do with poisons found in Australia, not just drugs, and it will go through a standardised classing of those particular substances. The Narcotic Drug Act looks at solely the use and distribution of narcotic-based drugs. Now when we move down into state acts, every one of the state acts and regulations that are written derive some way of interpretation from the Commonwealth. Now they can have some differences, and the way that happens is a state act is written and then all of a sudden Commonwealth legislation changes and the state doesn't pick up on it. So there can be differences within, and if there is differences, the Court of Law, often the Commonwealth legislation will overrule. Now that's becoming less common these days because we have governing bodies in place that regulate that. Now depending on what state you work in, each one of those states is going to have at least one act and a whole bunch of regulations that govern the use of medication. So Queensland, for example, because that's where our PCCM comes from and where most of the health services are found, is Queensland for the military. We have the Queensland Health Act, and from there the regulation for health, drugs and poisons regulations has been written, and that's the one that governs all the use, storage, and different levels of prescribing and administration rights within Queensland. And when we look at the scheduling of medications, I know you're all fully aware of this. There's 10 schedules found in Australia, and 4 of them relate to medication. So Schedule 1 is reserved just in case something new and exciting comes out. Schedule 2 is all about the pharmacy medications. Now these are the drugs that can be found in a pharmacy only. Those drugs that you find in supermarkets, they're actually non-scheduled drugs. So paracetamol, that sort of thing, can be found in a supermarket, but only less than 20 tablets. If it's more than 20 tablets or it has any mixture within it, then it must be found in a pharmacy or a regulatory or an authorised dispensary. Schedule 3 you can only get from a pharmacist itself, and Schedule 4 medication is for prescription only. So only prescribers can dispense. Only prescribers can prescribe, obviously, Schedule 4. Now, a special sort of Schedule 4 is Schedule 4 restricted, often known as S4D, so Schedule 4 dangerous. And they're drugs that are still Schedule 4, so prescription only, but they're treated as controlled drugs, Schedule 8. So these are drugs of dependency or abuse. They often get stored and have the same storage requirements as your Schedule 8s. Schedules 5 through 7 are different types of chemical poisons that are used mostly by agriculture. Schedule 8 is obviously our controlled drugs, 9 is all the illegal drugs that we can have, and 10 is any substance that has been deemed to be such a great risk to the human race that the sale and supply are completely illegal. Now when we look at drugs, there's a few things that you guys should know, and if you do already know, you should think about how it applies to you, especially when you're doing an integ work or how we operate within our units. So when you're working in a hospital, this is pretty important for us to know because it's often blurry lines, is the administration of any S2348 drug has to be directly on a medical officer's oral or written orders. So it has to be given as orders. Now that differs slightly for us when you're operating as an integ. We have legislation that says that anything in our protocol, the PCCM, that is S2, we can administer ourselves. Anything that is S3 and above must be given by a medical officer's order. Now in the event that you're given a verbal order, mostly in a hospital, that medical officer is required to provide that order in writing, usually within 24 hours. And the standard procedure for receiving a telephone order in hospitals is to receive the order, write it down, read it back, and then get a second nurse to read the order back to the MO in order to make sure it's correct. Now in the event that there's some confusion, say you're sitting out at Coltana and you get a telephone order from a doctor, which is our protocol, is what we're supposed to do, and there's some confusion, the doctor says one thing, you hear it as the other, and you give the wrong dose based on the order, then you are liable. You're the one that has made the medication error, therefore you are the one that are liable for prosecution within that case, especially if something goes wrong. So if you're ever receiving a verbal order, it's recommended that you write it down and check it a number of times if unclear with the medical officer. And for the medical officers, it's highly advisable that you write the order down, because if you don't have any record of that order, then essentially it never happened and you're both up for prosecution. In regards to recording of S8s and S4Ds or S4Rs, they obviously need to be recorded in a ward book and locked in a safe. The safe has to be bolted to the wall and the floor, be certain thickness, certain lock. It's all written in literature. But the big thing about the ward book is everything that goes in and out, including wastage, so anything that you discard, not give to the patient, has to be written in the ward book. The date and time of administration, including the patient's name, and the quantity of drug that is still left in the safe must be there, and you just need a signature. A signature on that particular one is needed. Now, believe it or not, there is actually no requirement at all to have witnesses or dual signatures at all for S8s or S4Rs, but it is often local policy to do so. So even though it's not written in any regulation or act, it is often put down as local policy or standing orders that it must be done. So don't fight the beast and just get that second signature. The last one that is interesting for you to think about is, by regulatory law, all S4s need to be inaccessible to the public. So whilst we're on base, it's in the pharmacy or in a locked room that meets the requirement. It just has to be locked. It doesn't have to be a safe or anything like that. Just anyone that shouldn't have access to it, shouldn't have access to it. So it's usually pretty good. When you're working as an intake, you're in the back of the vehicle, you have the box, you're there, it's pretty much inaccessible to the public. But maybe the loading of S4s into the back of ambulances, keeping the ambulances unlocked, therefore public access, may be something that you'll need to think about. Now, on top of law, we have a certain set of principles that fall under common law, and these are principles of negligence. Now, when we talk about negligence, it basically means that if there's ever an act or an omission that causes harm in the circumstances, but where that harm was reasonably foreseeable if due care was taken, then you are liable for negligence. Now, to protect this, protocols are often written, protocols that dictate best practice, but be aware that protocols can be outdated and often are outdated because they're written by someone who has enough foresight or diligence to do so, and then often get untouched for a long period of time. So if you see a protocol or a piece of writing that doesn't quite meet the mark, bring it up. Okay, I've made a whole career out of updating and bringing up problems with protocols, so it definitely exists. Now, as it regards to a principles of negligence, it is your requirement to do what is expected of clinical staff when dealing with medication. So if it's expected that you do the 5 rights and the checks, and you don't and something goes wrong, then you're negligent, obviously. You need to be very, very careful if there's unclear orders, written or oral. If there's an unclear order that's written and you give it to someone to look at and they take their best guess at what it is, that is not clarifying the order. And if you give it based on incomplete information, then it is you that is liable, not the medical officer. If you receive a telephone order, as discussed before, okay, you get it wrong, you can be liable. Now, in regards to standing orders means that in the event that something goes wrong, or the event that you're caught in a situation where you can't get hold of the MO to give that verbal order or to give the medication, then what are you going to do? What are you going to do in an emergency situation? What is in place in order to protect you? So a lot of that falls under the PCCM for us, okay, but you need to articulate that with the doctor who is signing you off for your authority to carry, because they need to agree that yes, in the event that a traumatic emergency situation, you were to follow the protocols within the PCCM, you still need to have that conversation with them to make sure that you are both on the same page, therefore making it a standing order. Okay, so that's the legal side of the house done. Now let's move down into ethics. Now, ethics are far more complicated than legal. Legal is quite simple. It says this is law, you can't do it, therefore regardless how you feel about it, that's it. Ethical side of the house is a bunch of principles based on morals, and these morals govern a person's behaviour or the way that they conduct themselves in an activity. Now, the problem with ethics is there's always a mix between personal morals and expectation. Now, that's what makes ethics very, very difficult. So the true sense of ethics are not law. Okay? Law overrule ethics all the time. For example, if you ethically believe that euthanasia is a good thing, the law in Australia says it's not. Therefore, if you are required to give a medication to someone who you believe is in pain and would be better off just going through euthanasia, legally you'll still have to do it. If you do not like treating drug dealers, treating the enemy combatants, it doesn't matter, it's all law, you have to do it, and your ethics have to take a back seat to that. Now, when we move into something known as code of ethics, now technically a code of ethics is not ethics. I mean, ethics is quite personal to somebody. A code of ethics is a professional expectation or agreement of how a profession should act ethically. Now, when you are met with code of ethics for being a soldier or being a clinician, it is a very, very good idea that you think about it. Your ethics can be governed, they can be changed, and they can be opened to evolving based on situation and experience. So instead of being closed-minded on a certain situation, you do have the duty of professionalism in order to look at the code of ethics, therefore the level of expectation that has been placed on you within that profession, to act towards those sort of moral standings. Now, public opinion and ideologies, they're what they are. They are people, usually ill-informed information that do not govern the way that you have to think. Just because everybody thinks a certain way, you don't have to think that way. And just because you think a certain way doesn't mean that they all of a sudden become the ethical principles that everybody has to stand by. And that goes true with orders. Orders are things that need to be followed. You have the duty of care, ethically and legally, to question orders that are unclear, and even orders that don't make sense. There has been cases in the past where nurses have gone to jail for killing patients following orders of the doctor. Now, granted, that happened back in the 1920s, but it's still something that can happen, and you definitely have the right and the obligation to question orders if they don't make sense to you, medication speaking. So we look at ethics that are indicative to nursing or indicative to healthcare. They bring it up to 6 main principles. And now these 6 main principles can vary in certain situations. Some are stronger than the other, but the 6 ones are ones that you can pretty much relate to. Now, there's a lot of literature out there that only mentions 4 principles, but veracity and confidentiality, I think, play a very, very big role in ethics. So the first one is autonomy, and that is ordaining your patient with enough information to make informed decisions. Okay, so it is absolutely your duty to gain consent. Something that we do quite terribly is gaining consent, especially in the emergency space, but even in the REP, giving a vaccination. Don't give any information on the vaccination. Expectation is they roll up, sleeves rolled up, no questions asked, and it's given. That is not following an ethical principles of autonomy. You need to give information so the patient can have informed decision making, and consent is the big one for autonomy. Now, when we look at veracity, it is basically the truth telling side of the house. So we can't coerce or lie patients into taking medication. Now, ethical principles, I'll just mention, move across the entire spectrum of healthcare, but I'm focusing on the pharmacology side of the house, so we don't go down a rabbit hole that will never ever end. So truth telling in regards to medications is absolutely required. The person needs to know what the medication is, what's it for. There's very few circumstances where the truth isn't the best course of action for your patient when dealing with medication giving. Now, there is a level of detail in which you need to decide needs to be given. So obviously, if you were to provide all the information on the medication available, you'll be there all day, and most likely the patient wouldn't understand without going through more information of the basics of pharmacology and pathophys, anatomy, physiology. It would just never stop. So there is an ability to withhold certain information as long as that information doesn't inadvertently coerce somebody into taking that medication. That's where ethical principles come in for that one. Now, long maleficence is pretty easy. Okay, it's doing no harm. You'll think that I never do anything harm, so that's nice and simple. But in the event that you don't follow your duties as they're expected in regards to medication management and medication administration, then you are failing to follow the principle of non-maleficence. It's that simple. You should have done something, you negated to do it, it caused harm, therefore you didn't follow that principle. Now, beneficence is often misconstrued as non-maleficence, but it's slightly different. So this is the principle where we're looking at doing more good than harm. So it often comes into play where certain practices that we're forced to follow result in more harm than good, or vice versa. Now, an example of that is if you don't follow one of the other ethical principles and it ends up being harm, then beneficence comes into play. Because if you did something, chances are harm wouldn't relate. Now, as far as the ethical dilemma goes for this side of the house, this is where palliative or aged care often plays a part, where we look at the do not resuscitates or advanced resuscitation protocols that have been placed in. So if you have a personal view or an ethical view that giving medication is only going to prolong someone's suffering, but you're doing so because it's a professional or legal requirement, then we have a ethical dilemma. So it's quite difficult to pin down, and often one that brings up a lot of controversy especially in the healthcare industry. Now, justice is another small world versus big picture sort of problem, and it's associated with getting equal access to resources. Now, things that are within your centre of control is what's usually associated as the micro allocation. So if you yourself, your micro allocation may be time or due diligence given to each particular person. Therefore, ethically, you're following justice. Now, the more you know and the more you travel and the more things that you're exposed to, you'll realise that on a large scale, or a macro allocation, justice is very, very rarely obtained or followed. Now, it's not because the rest of the world is looking at the big picture, doesn't want to follow that ethical principle. It's all got to do with availability. Now, what I mean by that, if we look at Australia and healthcare, if you look at chemotherapy, for example, if you live in a large metropolitan area, you get good access to chemotherapy or renal care or anything like that, for example. Whereas you live in a rural or remote area, it's a long distance and a lot of resource management requirement in order to get that same level of care. So macro allocation is very, very difficult and often is met with a lot of ethical dilemmas, especially when we start opening it up outside of medication, when we look at the availability of equipment, resources, things like that. But within your centre of control, your micro allocation, you can follow the principles of justice by essentially doing the same, giving the same care or the care required to individuals regardless of external variables, if you will, so like time, how much you like the person, anything like that. Now, last one, confidentiality. That's an obvious one in our line of work. So anything we do with patients, if anyone else doesn't need to know about it for clinical reasons, then we just don't talk about it. Okay, we keep it to ourselves and we don't pass that information on. Okay, nice short one. Hopefully this brings up a lot of thoughts in which will provoke the way that you do practice. Is obviously a much larger topic that can keep going on for a significantly long period of time, so we'll stop it now when we can. Just be aware that you are required to know your legal stance, and your professional conduct should be used in order to shape your ethical principles. Until next time, take care.